Hey, dear colleagues, so we will start our section on uveitis. I'm very happy to present you. We will have three reports of our foreign colleagues. Very actively and fruitfully we cooperate, and more than that, we have a friendship relations with Herbert Professor and Ioannis Papasavis. These are first two reports. Is a center of specialized specialized the first report is Herbert Professor, PhD, Lausanne University, retinal vasculitis at birdshot uveitis.
Colleagues and friends in Ukraine, I would like to thank you for your kind invitation to the 2025 Filatov Memorial Lectures. It is remarkable that in such difficult times you are able to maintain the tradition of the yearly Filatov Congress, and I would like to congratulate you for this. I am missing Odessa very much, and I'm yearning to be back as soon as possible. I was asked to speak about retinal involvement in birdshot retinochoroiditis, which is often neglected in the appraisal of birdshot. Birdshot is known as a choroidal disease mainly, and its hallmark is represented by the typical rice-shaped, depigmented choroidal birdshot lesions. However, when these lesions are clinically detected, the disease is already at an advanced stage. Birdshot is indeed a stromal choroiditis, such as Fock-Koinagi-Harada disease, but not only. It is characterized by a dual independent retinal and choroidal involvement. Here you see the choroidal involvement, and here you see the typical retinal vasculitis. Now, what is the chronology of the disease? This is crucial to understand birdshot. Retinal vasculitis is often not associated in the mind of people with birdshot. The classical presentation of birdshot is that of a retinal vasculitis which the clinician is not associating with birdshot. The patient is treated with systemic corticosteroids. He gets better. Steroids are discontinued, after which inflammation comes back. Retinal vasculitis is underestimated in birdshot. The aim of this study was to determine whether birdshot retinal vasculitis had a specific diagnostic pattern to lead to the diagnosis. We analyzed 21 patients. 65% of them were female, 35 male. The mean age is characteristic, namely 52.4 years. HLA A29 was positive in all cases. Now, all 21 patients had retinal involvement. 24% of them, 5 out of 24, had no choroidal birdshot lesions, with choroidal involvement only diagnosed by ICGA showing hyperfluorescent dark dots, HDDs, on angiography. You can see these hyperfluorescent dots in a case where no clinical birdshot lesions are visible yet. If specificity of birdshot retinal vasculitis can be demonstrated, this would be a crucial element to lead the clinician to suspect birdshot, perform ICGA, and subsequently search for HLA A29 and make the diagnosis. Here are the results of our study. Retinal vasculitis was present in 100% of cases, and it is a very typical vasculitis with sheathing on fluorescein angiography of the large posterior vessels, as you can see, especially here and here. Second characteristic, profuse leakage. As you can see here in the posterior pole, the leakage is enormous. This is a very leaky vasculitis. Macular edema is present in 81% of cases also. And what is very specific of this macular edema is that very often it is sparing the central fovea, which is occurring in 82% of those patients that have macular edema. Now, a very typical finding in retinal vasculitis of birdshot is what we call retinal arteriovenous circulatory pseudo-delay. In 1981, Gass described arteriovenous circulation delay, which in fact is a pseudo-delay. Due to profuse intraretinal leakage, there is insufficient fluorescein to mark the veins. If you take ICGA frames, you can see that in this case, after 25 seconds, already there is perfusion, which is absolutely not shown on fluorescein angiography, because all the fluorescein has gone into the retina. Therefore, this phenomenon has to be called pseudo delay of perfusion. Of course, Don Gass in 81 could not know this because ICG was not available. And as the ICG molecule is very large, it cannot go out of the retinal vessels and is truly marking the course of retinal vision. So pseudo delay is a very characteristic finding in birdshot. Here a few other examples of pseudo delay. which we found in 81% of our patients, and the mean pseudo delay in these patients was 46 seconds. Now, one other characteristic finding in retinal vasculitis due to birdshot is what we call the sheathing staining of large posterior vessels, which you can see very easily here, and in this case here, and in this case here. And this occurred in 62% of our cases. This sign was found to have a high sensitivity and specificity, as well as a positive predictive value for birdshot in a study performed in 2024 by Dr. Lee in the United States. More recently, there was another publication that attracted the attention to the profuse disc hyperfluorescence in birdshot retinal vasculitis, which amounts to 100% of cases. Another finding, which is less frequent, but when it is present, it is very useful to orient the clinician towards birdshot retinal vasculitis. And these are thick vitreous strands, which we found in as much as 35% of cases. And you can have a look here at a few cases with these thick vitreous strands due to vitreous infiltration in the birdshot. Here is a practical example of a birdshot case with retinal vasculitis. You have the thick strands here. There is a fuzzy fundus with no foci yet. There is pseudo delay. There is a vitreous field defect, which, by the way, you will find, even if it's not very pronounced in 100% of birdshot cases, this is one of the diagnostic parameters which will help you to make the diagnosis of birdshot. So you can see here also the retinal vasculitis, including sheathing, as well as hot discs. In this case, the fluorescein score was calculated to be 10. The type of retinal vasculitis is often compatible with birdshot, but this still has to be proven. In this case, we performed ICGA, and of course we found stromal HDDs, numerous and regularly disposed hypofluorescent dots. And of course, in this case, HLA A29 was positive. Retinal vasculitis precedes clinical choroidal involvement. Identifying a specific vasculitis pattern compatible with birdshot can orient the clinician to suspect the disease and lead him to perform ICGA and search for HLA A29 if we found the characteristic choroidal involvement, even HDDs and regularly disposed. This allows an early diagnosis before the appearance of choroidal birdshot lesions. If you treat the patient at this stage, the birdshot lesions will never appear. In summary, the choroidal lesions are very remarkable. As we say, these lesions bark because you can mention them, but they don't bite. However, the lesions that determine the morbidity of the disease is the retinal vasculitis. The whole appraisal of birdshot was obnubilated by the dominating clinical image of birdshot choroiditis, oval-shaped, depigmented lesions, which, when they are present, already determine that the disease is well advanced. We performed a score of retinal vasculitis, which is shown on this slide here. Profuse retinal leakage, edema, foveal sparing, pseudo-delay, sheathing staining of large posterior vessels, profuse disc hyperfluorescence, and thick vitreous strands. If you have a score of 9 or more, the probability was, in our hands, strong for birdshot disease. 14 out of our 18 cases, which we retained for this analysis, were positive, means true positive. 4 of the cases were negative, means false negative. We chose 18 cases of controlled retinal vasculitis. In these cases, 16 out of 18 were true negatives, and 2 out of 18 had a score of more than 9 and were false positives. This is an example of how we score. We have here profuse leakage, thick sheathing of posterior vessels, profuse disc hyperfluorescence, 2, 3, and 2. We have a pseudo-delay, which is scored 3, and we have macular edema and foveolar sparing. So this is a typical case of retinal birdshot vasculitis. The score was numbered at 14 out of 16. This is another example. As you can see here, profuse leakage, macular edema with relative foveolar sparing, profuse disc hyperfluorescence, pseudo-delay, which gave us a high score as well. This is another example. We will go over this. Now, birdshot retinal vasculitis score had to be validated by comparing it to retinal vasculitis cases of different etiologies and determine sensitivity, specificity, and positive predictive value for these findings. We performed a second study, and as told before, we chose 18 cases of birdshot vasculitis and 18 cases from other vasculitis from other uveitis entities. Now, the mean score of the birdshot group was well over 9, 10.5, whereas the mean score of the control vasculitis group was 3.9. Probability of mean score of more than 9 correspond to birdshot significantly higher than in the group of non-birdshot cases, and this was significant. Now, the predictive value of a score of more than 9 for birdshot was calculated to be 88.9. So retinal vasculitis in birdshot precedes clinically visible choroidal lesions. It presents as a specific pattern, allowing to orient the clinician to suspect birdshot, to perform ICGA, and in case of positivity, to search for HLA-A29 antigen to reach an early diagnosis. If treatment is started early, choroidal birdshot lesions never will develop. I would like to thank you very much for your attention, and I'm so happy to be among you in these difficult times. Thank you.
Щиро дякую вам, професор Герберт.
Thank you very much, Professor Herbert. I'm really glad to see you, at least on the screen, and I hope so much that we will meet in Odessa offline, and we will meet you, and you will participate in our conference offline, and we will hold the course that we had planned to hold. Thank you. Can you hear us, Professor? Thank you. Так.
I have difficulty hearing you.
Давайте повторим.
Давайте
повторимо.
So, dear Professor, we are really grateful for you, for your report. And we are glad to see you, at least on the screen. Thank you very much. We hope that we will meet you offline in Odessa, and our plans that we had made before will be able to be done. So we invite you with Ioannis to Odessa as soon as the peace comes.
Thank you very much. I'm very glad to be with you.
Thank you very much. Thank you.
Thank you.
Наступна доповідь Ioannis Papasavas, також Центр спеціалізованої офтальмологічної допомоги, Лозанна, Швейцарія. Також він є Honorary Research Fellow in Uveitis, Moorfields Eye Hospital. Доповідь «Взаємодія між імуносупресивними агентами».
Good evening, everyone. My name is Ioannis Papasavas. I'm an ophthalmologist based in Lausanne, and I would like to thank the Science Committee for inviting me to participate to these lectures. I'm very happy to be part of this, and I'm gonna talk to you about interaction with immunosuppressive agents to be avoided. So, actually, in uveitis, we're using a lot of immunosuppressive treatment, which is very important to understand the interaction that we have with other drugs. And what is called interaction actually is when one drug affects the absorption, distribution, metabolism, and elimination of the second drug. Why is that important? This is important because interactions can significantly increase the serum levels of one drug, which means that automatically increase the deleterious side effects that this drug can cause to the patient. On the other hand, it can decrease the serum levels of the drug, which means decreasing the efficacy of the immunosuppression, and this can result in worsening of the autoimmune disorder that we are trying to treat. So important pharmacokinetic and pharmacodynamic drug-drug interaction occur when two immunosuppressants are given on the same time or one immunosuppressant with another drug. So in the metabolization of the immunosuppressive treatment, the cytochrome P450 enzymes are very important. These are a group of methylate proteins that comprise a superfamily of related enzymes subgrouped into families, subfamilies based upon the similarities in amino acid sequences. As we can see here in this table, a lot of immunosuppressive treatment and immunosuppressive agent are metabolized via the cytochrome P453A4. For example, the cyclosporine, tacrolimus, and the corticosteroids. So this means that most of our drugs can interact with this cytochrome and create drug-drug interaction. Starting with the glucocorticoids, which is our first choice of treatment, prednisone is known that is a prodrug and must be metabolized to prednisolone in order to be active in our body. So the glucocorticoids are metabolized by the cytochrome P453A4, and it is also believed to be an inducer of this enzyme, which means it can increase its activity. Some drugs like ketoconazole and diltiazem, they are inhibiting the 3A4 enzyme, which means that can increase the level of prednisone and prednisolone and thereby increase the toxic effects of these drugs. On the other hand, phenobarbital or rifampicin are inducer of 3A4, which means they're activating this enzyme and can enhance the metabolism of glucocorticosteroids, which means they can decrease their levels. We are moving forward to calcineurin inhibitors, which actually is the first choice of patient with transplantation. And that's for this reason, we have a lot of studies that are evaluate the interactions of these drugs with other drugs, other immunosuppressive and other antibiotics. That's why we have a lot of elements, and I will present to you some of them. So if we have to remember that cyclosporine can cause nephrotoxicity and neurotoxicity. That's why it's important to control and not having elevated levels of this drug in our system. The absorption of cyclosporine is affected by both the P-glycoprotein and the 3A4 enzyme. So the P-glycoprotein is responsible for clearing cyclosporine from cells into the intestinal lumen, and the 3A4 enzyme is responsible for metabolism of cyclosporine in the intestines and in the liver. There are a lot of drugs that can increase the cyclosporine levels by inhibition of the enzyme. Some of them are ketoconazole, fluconazole, clarithromycin, erythromycin, verapamil, diltiazem, which can be used for high arterial pressure, allopurinol, atorvastatin, simvastatin. But not only drugs. We can have foods also that can increase the cyclosporine levels, such as grapefruit juice. And there are studies that have shown that can increase up to 200% the area under the curve of cyclosporine. And what is the area under the curve? Actually, is a meter that can show us the level of the drug inside our system. So the higher this area, the more of the drug. That's why it's important to know and also ask our patient if they have a routine, for example, to drink grapefruit juice before prescribing them cyclosporine. As we said before, treatment for the high arterial pressure, such as verapamil and diltiazem, can create a reduction of the cytochrome 3A4 activity, which means that we have higher levels of calcineurin inhibitors in our system. There are reports that showing that are happened in transplant patients with prescribing that people with cyclosporine and treatment for depression such as nefazodone or fluvoxamine had increased cyclosporine toxicity. A herb that is known in UK, it's called the St. George wort, is given for mild depression, has reported to decrease the cyclosporine levels. And this is something that we can find like in our garden and in our pharmacy without doctor prescription. So it is very important to ask our patient about their habits, ask our patient about the drugs they're using, but also if they're using other supplements or some food routines. Tacrolimus, for example, is another calcineurin inhibitor which is similar to cyclosporine. Here we can see that tacrolimus can have synergetic nephrotoxicity with amphotericin B, erythromycin, ibuprofen, and also there are other drugs that can reduce the level of tacrolimus, and in this study was done in transplant, so giving a rejection of the transplant, but in our case can reduce the effect of our drug to control inflammation. So this is a table that summarizes the interactions of cyclosporine and tacrolimus with other drugs. As we can see, the increased level of cyclosporine can happen by antihypertensive treatment like diltiazem, verapamil, similar with the tacrolimus, can happen also with antifungals, with antibacterials, and with food like grapefruit juice. And decreased level of these drugs can happen by rifampicin, which is an anti-TB treatment, with some herbs like St. John's wort, and with anti-epileptics. Moving on to mycophenolic acid and mycophenolate, which is another important immunosuppressive treatment. And mycophenolate has its immunosuppressive effect by interfering with the lymphocyte proliferation, inhibiting inosine monophosphatide dehydrogenase, which is an enzyme necessary for the synthesis of the nucleotide guanine. When we're taking orally, the mycophenolate mofetil is rapidly hydrolyzed and to the active drug, which is the mycophenolic acid. The major metabolism of mycophenolic acid is via glucuronidation. There are studies that have shown that the levels of mycophenolic acid are higher in regimens combining tacrolimus and mycophenolic mofetil compared to regimens combining cyclosporine and mycophenolate. There are also other studies that have shown that the concentration of cyclosporine was decreased after the use of mycophenolate. As we can see here, the levels of cyclosporine were higher before mycophenolate compared to the levels after mycophenolate. Another drug that is also used for immunosuppression is azathioprine, which interferes with the DNA and RNA synthesis and exerts its autoimmune action by inhibiting the differentiation and proliferation of T and B lymphocytes. Azathioprine is metabolized by thiopurine methyltransferase, which is an enzyme, TPMT enzyme. It's very important to know that this enzyme is not present in all people, which means that there are differences between people, so we have to evaluate the activity of TPMT before prescribing azathioprine to our patient, because if the activity is low, this patient cannot metabolize azathioprine. It can cause toxicity and side effects. It is known that there are interactions between azathioprine and warfarin because azathioprine is increasing the clearance of warfarin, and it is also known that a combination of azathioprine and allopurinol can cause leukopenia. Moving on to methotrexate, which is also a common immunosuppressive drug. It is known that there are interactions with penicillin and other non-steroidal anti-inflammatory drugs which affect the pharmacokinetic parameters of the methotrexate. A very important side effect, which is aplastic anemia, can happen with concomitant prescription of sulfonamide, trimethoprim, chloramphenicol with methotrexate, and this is happening because this drug displaces methotrexate from its binding to albumin and can increase the free plasma concentration of methotrexate. There are reports that talking about interaction with barbiturates and tetracycline, furosemide, and with methotrexate. And even though we talked before that aspirin and the other non-steroidal anti-inflammatory drugs can slightly decrease the renal clearance of methotrexate, this is not clinically significant. So the toxicity of methotrexate is not significant. And in patients that have very high dose of methotrexate with decreased renal function and has to use aspirin or non-steroidal anti-inflammatory drugs, it's better to think about the reduction of the dose of methotrexate. So this is a table which summarizes the interactions between the immunosuppressive agents. So as we talked before, we have cyclosporine, which actually increase the levels of tacrolimus. It's not very the interaction with the steroids is very variable, so we have to be careful and monitoring our patient that having concomitant cyclosporine and corticosteroid treatment. And as we saw before, the levels of mycophenolate can be decreased by the use of cyclosporine, and on the other side, cyclosporine can be decreased by the use of mycophenolate. So tacrolimus similarly can decrease the levels of corticosteroids, so has to be careful. And using tacrolimus with mycophenolate, we can have increase of the levels of tacrolimus. Moving on to the biologics, I'm not going to talk about etanercept because it's not very used in uveitis as it can induce uveitis itself, but adalimumab and infliximab are two drugs that are very used in our patient, and actually it's our first choice of a biologic agent, especially adalimumab. So it is reported that methotrexate can decrease the clearance of adalimumab by 29% for a single dose or 44% for a multiple dose. But these interactions were not clinically or pharmacokinetically significant. And that's why there are a lot of regimens that are using methotrexate with adalimumab because methotrexate can prevent the appearance of antibodies against adalimumab, which can neutralize the effectiveness of adalimumab. Similarly, there are regimens that includes infliximab and methotrexate. In this case, there are not significant interactions between infliximab and methotrexate. Other biologics that are used in our patient is the most common is rituximab, which has no known interaction with other drugs. Similarly, anti-interleukin-1 has not known interaction with other drugs, and anti-interleukin-6 has not known interaction with other drugs, although it's not recommended to associate with anti-TNF-A because can increase the side effects. So we pass in drug-drug interaction between antiretroviral and immunosuppression. It's not that common, but we can have patients that having anti-HIV treatment and need immunosuppression. It is reported that the co-administration of corticosteroids and antiretroviral drugs can show increase of the concentration of corticosteroid because the antiretroviral treatment can inhibit the cytochrome 3A4. Similarly, they can inhibit in patients that having cyclosporine. So by inhibition of the cytochrome 3A4, they can increase the cyclosporine levels, and this can mean that can increase also the side effects. Finally, I would like to talk about the drug-drug interaction between anti-tuberculosis treatment and immunosuppression. We have patients that are diagnosed with tuberculosis-related serpiginous choroiditis, which actually need concomitant immunosuppression and anti-DBT treatment. It is known that rifampicin is a potent inducer of the cytochrome P450, which means that can increase the activity of the cytochrome, and by consequences, it can decrease the concentration of cyclosporine. Similarly, rifampicin can decrease the level of prednisolone by increasing the metabolism of prednisolone, and is reported that it can increase clearance by 45%, which means that half of our treatment goes away. And that's why in Moorfields Eye Hospital, when we were prescribing rifampicin with prednisolone, actually we were doubling the dose of prednisolone. And similarly, rifampicin can significantly increase tacrolimus, which means that can decrease its effectiveness, can decrease its oral bioavailability by 50%. So patients that need anti-TB treatment and immunosuppression, we have to be careful because the interactions between those treatments can decrease the effect of our immunosuppression. These are my references, and again, I would like to thank you for your attention, and the Science Committee for the invitation to these lectures. Thank you very much.
Дуже рада бачити вас, Іоанніс.
Very happy to see you, Ioannis, even in online. I remember the last summer and our meeting, and I hope that we will see you soon in Odessa, as well as we had this meeting last year in Lausanne. So we will be very happy to see you after our victory in our prosperous plus in Odessa with the report, and as our guest we will be very happy to see you here. Thank you very much for your report.
Thank you very much for the invitation. I'm very glad to be part of this. Hopefully next year we'll be in person. I've never visited Odessa, but I heard a lot of stories from Professor Herbert, so I'm looking forward to keep doing what I'm doing. It's great that you are still organizing all that. Have courage, and I'm happy to be with you even on screen. Thank you very much, and good luck, and to the continuation of your effort and this Congress. Thank you very much.
Thank you very much. Наступна доповідь.
The next report of Professor Masaru Takeuchi, Japan Professor of the National Medical College of Defense, comparison of causative diseases of uveitis before and after COVID-19.
Free audio post-production. Biophonic.com.
Hello, Alexandra. Thank you for inviting me to give a lecture in this meeting. I'm truly sorry that I wouldn't be able to attend the meeting virtually. How is the weather over there? Here, it already feels like early summer. It's been 7 years since I was invited to Odessa for the last lecture. Time really flies. Well then, I'd like to start the lecture now. Today, I'd like to talk about comparison of complicated diseases of uveitis before and after COVID-19 pandemic. COVID-19, short for coronavirus disease 2019, is an infectious disease caused by the SARS-CoV-2 virus. It emerged in Wuhan, China in December 2019 and rapidly spread across the globe, leading to the global pandemic. WHO declared the end of COVID-19 as a public health emergency of international concern on May 2023. However, the virus continues to circulate and mutate, causing recurring waves of infection.
In a matter of days, Dr. Li Wenliang went from treating patients to becoming one. The 34-year-old ophthalmologist diagnosed Saturday with the Wuhan coronavirus, dying less than a week later in the same hospital in which he worked. But if action had been taken when he and others started sounding alarms, the severity of the outbreak might have been understood sooner. Struggling to communicate, Li spoke with CNN briefly by phone on January 31st. You could hear the hospital machines pulsing in the background.
You will remember this video aired at the end of 2019. It shocked many people, including Li. This slide is showing cumulative confirmed COVID-19 deaths, March 21st, 2023. The purple color gets darker according to the number of deaths. There have been 7 million reported confirmed COVID-induced deaths worldwide. As of January 2023, taking into account likely COVID-induced deaths via excess deaths, the 95% confidential interval suggests the pandemic caused between 19.1 and 36 million deaths. The left-hand side of the slide shows the top 10 countries for recorded COVID deaths. The highest number is in the United States, followed by Brazil, India, Russia, and Mexico. As shown on the right side of the slide, regarding COVID deaths as a proportion of the population, the order was Peru, Brazil, the United States, Italy, and United Kingdom, Mexico, and Russia. Searching a PubMed for COVID-19 yields 451,000 papers. Furthermore, searching for COVID-19 and uveitis results in 500 pages. On the other hand, DNA vaccine against SARS-CoV-2 was rapidly developed to combat COVID-19 pandemic, marking the first clinical application of DNA vaccines. Given that entering COVID-19 vaccines into PubMed yields 52,000 results, which is one order of magnitude less than 450,000 hits for just COVID-19. Furthermore, searching for COVID-19 vaccines and uveitis results in 178 hits. However, at that time, our lives were also strictly controlled and thrown about 3 Cs to prevent COVID-19 infection. At crowded places, avoid gathering in groups where you can't maintain 6 feet distance from others. At close contact, wear a mask or maintain 6 feet difference when you are with people you don't live with. At confined spaces, avoid enclosed spaces with poor ventilation. Therefore, it's difficult to distinguish whether the onset of uveitis is directly influenced by SARS-CoV-2 infection from COVID-19, by the COVID-19 vaccine, by lifestyle changes, or by the accompanying stress from avoiding the 3Cs. It's possible that all of these factors are interacting with each other. Separately, the usual presentation or recurrence of uveitis without connection to these factors can also take place. Given that, we compared underlying diseases of uveitis patients who visited National Defense Medical College Hospital between 2011 to 2013, pre-op, and 2021 to 2023, post-op, and examined changes in their proportions. 277 patients, 113 males and 164 females diagnosed with uveitis between 2011 and 2023, pre-op, and 246 patients, 107 males and 139 females diagnosed between 2021 and 2023, post-op. There was no significant difference in the male-to-female ratio or in age distribution between the two groups. This slide shows etiology of uveitis in newly diagnosed patients in pre-op on the left and post-op on the right. Diseases that increased in post-op compared with pre-op are highlighted in red, and those that decreased are in blue. The top 6 uveitis etiologies showed proportional effects, but their composition mirrored nationwide epidemiology in Japan. Looking at these results, 1. Sarcoidosis and scleral uveitis remain relatively unchanged. Octogen disease and patient disease have decreased. In contrast, repeating anterior uveitis has increased significantly from 13 to 44 cases, and other infectious diseases such as CMV retinitis, cyclic uveitis, and ocular plasmosis have also increased. The representative causative viruses of hereditary anterior uveitis are herpes simplex virus, varicella zoster virus, and cytomegalovirus. These anterior uveitis are characterized by unilateral anterior granulomatosis uveitis with elevated intraocular pressure. Therefore, definitive diagnosis lies on PCR testing using ECAS film, but each presents with distinct clinical findings. In HSV anterior uveitis, corresponding to the area of corneal endothelial lesions, roundish, faint keratic precipitates are observed on the posterior surface of the cornea. Visibly, anterior uveitis shows various sizes around bottom part keratic precipitates are densely observed in the central cornea. These develop pigmentation over time. On the other hand, in CMV anterior uveitis, keratic precipitates are often observed in the lower central cornea, and they vary in appearance from fine dots to white round regions resembling coin regions, those similar to post-National syndrome, and those accompanied by pigmentation. Next, we extended study period by 1 year to increase the number of herpetic anterior uveitis cases and compared the proportions of causative viruses of herpetic anterior uveitis between the pre-COP period 2011 to 2014 and the post-COP period 2021 to 2024. First, regarding the comparison of by age and sex, the mean age in the pre-COP group was 60.5 years, while it was 67.8 years in the post-COP group, showing a statistically significant difference. The male-to-male ratio was approximately equal, with no significant difference observed between the two groups. Regarding the comparison of PCR testing rates using ACAS humor, the rate in the pre-COP group was 67.9% and 37.1% in the post-COP group. Although this difference was not statistically significant, PCR testing was performed more frequently in the pre-COP group. This is likely because the increased incidence of herpetic anterior uveitis with ophthalmic doctor in the post-COP group. As will be shown later, reduced necessity for PCR testing. The PCR positivity rate was 36.8% in the pre-COP group and 51.3% in the post-COP group. Although this difference was not statistically significant, the positivity rate was higher in the post-COP group. Regarding the comparison of causative herpes viruses, in the pre-COP group, VZV was the most frequent at 47%, followed by HSV at 39% and CMV at 14%. However, in the post-COP group, VZV further increased to 61%, followed by CMV at 26%, with HSV at 13% being the least frequent. A statistically significant difference was observed between the two groups. During COVID-19 pandemic, through implementation with infection prevention measures such as mask wearing, hand washing, and social distancing is considered to have led to the decline in immunity against pathogens, potentially increasing the susceptibility to respiratory infections like influenza. This paper, entitled Increased Incidence of Endophthalmitis After Vitrectomy Relative to Face Mask Wearing During COVID-19 Pandemic, was published in British Journal of Ophthalmology in 2023. Our conclusion is herpetic anterior uveitis is caused by the reactivation of the herpes virus within the body. However, it is suggested that a decrease in immunity against the herpes virus, similar to that against external viruses, may have contributed to an increase in its occurrence after COVID-19 pandemic. Thank you for listening. How do you find the lecture? I apologize if it was a little bit difficult to hear in some parts. Please feel free to email me any questions you may have, and I'll be happy to answer them. I'm also looking forward to seeing you, Alexandra, and the other Alexandra again soon. See you.
І запрошуємо до наступної доповіді.
Okay, we invite for the next lecture, Alexandra Vladimirovna Zborovska, head of the Department of Inflammatory Diseases of the Eye, with the topic Rare Uveitis in Ukraine. Thank you. I would like to get back to previous reports. First of all, excuse me for strange translations, some artificial some problems with artificial intellect translation, speaking about birdshot. The word birdshot was incorrectly translated. And secondly, beginning my report about rare cases of uveitis in Ukraine and Ioannis's report when we met in Lausanne at the conference last year. It was a common conference of Muffen Hospital and Lausanne Hospital, and we discussed with my colleagues from those hospitals. And Ioannis was on practice, field practice in that hospital. He was so satisfied because he was able to see particularly those cases of uveitis which are rare in Switzerland, for example, taking into account the fact that Muffen Hospital is in London, and in London, as you know, there are really many migrants from other countries and continents. And there he was able to see alive so many pathologies which we had never seen before. And that is why, let us say, this inspired me to create this report. Some cases of uveitis were never seen by us, but that is not the reason why we should not know about them. Koyanagi-Karada syndrome. Earlier on, it used to be a rare type of uveitis because it has a clear ethnical association. According to literature, it is often met in nations with expressed pigmentations like Asian and Spanish and American Indian nations. It was also found in Romania, and nowadays we observe the change of pathomorphosis among our ethnic group and increase of number of patients with, let us say, non-classical form of Vogt-Koyanagi-Karada syndrome. So keep in mind that there is this pathology which is not always starts in our people's representatives with the similar picture, like gray hair, gray plucks of hair or eyelashes, or cirrhosis, meningitis, or visual acuity decrease, both eyes lesions, hearing impairments, serious inflammation of the internal ear. Really often uveitis prevails, but other symptoms arise earlier or do not arise at all. What concerns lesion of eyes, it's primary choroiditis, because this syndrome is an autoimmune reaction to melanocytes. Wherever they are located in the organism, this is just autoimmune reaction to any melanocytes whatsoever. There are several stages in this syndrome. This is prodromal stage. All these stages listed here are classic. The second stage is clinically present exudative stage, massive infiltration of choroidea with high level of inflammation, for example, in retina. It is both eyes, granulomatous, uveitis, massive fulminant cirrhose, exudative detachments of retina. This is papillitis, sometimes Dahlen-Fox nodes, and sometimes ophthalmologists who are looking at the posterior area, they do not look at it as carefully as possible. As well, besides these symptoms, we can also see impairment of hearing at this stage. Unfortunately, the next stage is chronic stage. If the clinical present stage was missed and the patient was not given the opportunity to be treated, then the condition transforms to chronic ones, and the fundus unfortunately looks like sun setting. In the acute stage, you can see cirrhose, exudative detachments of retina. Here is how they look in OCT. This is how the fundus can look like, and this is the final chronic stage. It's like burnt ground. This is how such fundus looks like at final stage if a patient failed to be treated timely. This is a photo of one of our patient who is Crimean Tatar. Actually, Turks and Crimean Tatars, they suffer from this disease. She came to us with Vogt-Koyanagi-Karada syndrome, and she is still suffering from it. She had cirrhosis, meningitis. She had pains, headaches. Nobody suspected Vogt-Koyanagi-Karada syndrome, and nobody did the punction to check if it was present. So uveitis was suspected. She underwent vitrectomy, and after all these manipulations, this is how her eye bulb looks like. Timely treatment includes standard prescription of corticosteroids, steroids, and immunosuppressors. There is nothing complicated there. The only issue is what specialist should treat this condition, because among our patients there was an Uzbek citizen with this syndrome, and he was treated by us because neurologists and rheumatologists refused from taking this case without meningococcal meningitis. So, in absence of this condition, just syndrome of Vogt-Koyanagi-Karada was treated in our department. West Nile fever, or as people name it, duck fever. We know that Odessa Oblast is not a natural place for this condition. It is passed from animals to people, but for today we are also an environment for this type of fever. In Israel, the first case was found in 1951, but the name comes from 1939. Massive foci of this disease were diagnosed in New York in 1999. Sometimes this disease causes spreading of sometimes untimely treatment causes spreading of such diseases all over the world. What is the problem with the Western Nile fever? This is 80% of infections do not bear any symptoms. This is probability of manifestation of heart complications in people over 50 years old. This is incubation period which lasts up to 2 or 3 weeks, whereas the fever period lasts about 5 or 7 days. And the disease is transmitted by mosquitoes. Which symptoms do we observe from the point of view of the eyes? This is multifocal chorioretinitis, this is active foci, this is early hypo and late hyperfluorescence. This is what we should keep in mind in order to choose the treatment tactics. Unfortunately, though, for now, the treatment is symptomatic because there is no proven system of therapy. Reactivation of vision is questionable, but sometimes in the condition there might be a good prognosis. And here are indeed rare cases of uveitis which started to be found in Ukraine. These are uveitis caused by arboviruses. Arboviruses cause Rift Valley fever, which is endemic for South and East Africa and Saudi Arabia. This is dengue fever, endemic to tropic and subtropic regions. Chikungunya, which is not a fever, and which is endemic to Indian subcontinent, Africa, and East Asia. All these conditions may either threaten life or have a very light, mild course. Speaking about Rift Valley, systematically this is a type of fever, increase of body temperature, and the slide shows how the fundus looks like in this type of fever. Dengue fever. In this condition, the fundus looks like this. There is usually macular edema, there is retina vasculitis, there is a ring-like macular edema, hemorrhages, and chikungunya, which is translated from Makondo language, from southeast Tanzania. The main thing that is impacted in this condition is joints. As to the eye lesions, this is non-granulomatous anterior uveitis, retinal vasculitis, retinitis, neuritis. So, as I said yesterday, the key factor in our success in treatment and diagnosing is collection of anamnesis. Systemic symptoms might be insignificant in these types of uveitis. So it is important to know where your patient traveled, who this person communicated to, Some of your patient's friends or family members might have traveled somewhere in Africa or in some Eastern countries, and they might be infected but without symptoms, and they might be considered transmitters of these diseases, these types of uveitis to your patients. Also, we should keep in mind that the basic lesion falls on the eyes, then correction of treatment has to take place depending on the eye lesion. Also, definitely, if you plan any type of surgery, then correction of dosage has to take place with regard to systemic preparations. How should one treat such a patient? For example, you are an ophthalmologist who is called to consult in some infectious department like Hayanagi-Karada syndrome. A patient is treated in neurology or therapy, and you, the ophthalmologist, is called to advise there. So what should you do? You should first of all and mostly provide local treatment, because after such patient is discharged from infectious department, for example, he or she is going to become yours, just your patient, just under your advice. So that is why monitoring of complication is of crucial importance. Besides, you have to timely use surgeries so that the critical condition is not reached, especially for Koyanagi-Karada syndrome, which can lead to terrible consequences. If your patient has a systemic disease and is, let us say, in condition when you can only use systemic treatment, then we cannot turn to subtenin injections in any case. We observe that subtenon and intravitreal injections are declined by many specialists. First of all, because the tuberculosis cases are arising, have been arising lately, and because their usage sometimes causes steroid glaucoma or increase of intraocular pressure. Regularity of subtenon injections of triamcinolone as well as vitreal injections, they increase the risk of steroid glaucoma significantly. Those who operated on patients with uveitis, they know what kind of work this is, because the result is questionable and it is difficult for both patient and surgeon. That is why we use, if you cannot use parabulbar infections or systemic therapy, or you have to strengthen the systemic therapy by increase of concentration, then you have to use the drops. We have lotoprednol, which has anti-inflammatory action and can be used twice a day. That's very effective if your patient has temperature, high temperature, 40 degrees, for example, then it is much more comfortable than getting these drops 4 times a day. So 2 times a day is much more comfortable and effective and proper. Speaking about allotoprednol, it accumulates in the structures of our focus, which are iris, for example. That is why, dear colleagues, we used to have a patient with tuberculosis, allergic uveitis, retinovasculitis, which looked absolutely untypical. She was diagnosed first with chronic thrombosis. And yesterday, by the way, we discussed chronic thrombosis, and then we diagnosed her with tuberculosis retinovasculitis, and she wished to consult in Israel. So I will never forget my Israeli colleagues' conclusion, which they gave her. So in connection with the fact that we have few cases of tuberculosis in Israel, we recommend to get advice and treatment in the residence area. So, even if we have really few cases of certain diseases, we are responsible to know about these cases, and I hope that whenever the peaceful times come, we will start traveling and we will be able to see more and more rare cases, because they could spread after these flows of people from one country to another. We will observe the developments, and especially it concerns the Fogg-Kanagi-Karada syndrome. Thank you very much, Oksana Vladimirovna. Are there any questions? So no questions for now. That is why we invite for the next
Кандидата медичних наук,
Дорохова Alexandra Ivanivna, candidate of medical scientists. So please, Alexandra Ivanivna, the floor is yours. Dear colleagues, in the treatment of uveitis, we can meet pitfalls and challenges in any case, in any stage, but of course, we understand that the success of treatment depends on the correct, established diagnosis. When we prescribe tests, we can do it using our head, of course. Sorry. So it's two sides of one medal. First of all, it's the lack of attention to necessary tests, and then increase attention to unnecessary tests. In order to balance this situation, it is necessary to pay attention to the clinical picture of uveitis. We all know that uveitis have the characteristical and usual clinical picture. We pay attention to its localization and type of inflammation, granulomatosis or non-granulomatosis. And before sending a patient to make a test, we will have a pre-established diagnosis, and we will understand what outcome we want to get. What about unrelevant analysis when we have uveitis? These are torch infections. I will remind you about healthy cariness, so the patient can be infected. So please pay attention to the number of people being infected. cytomegalovirus and Epstein-Barr viruses. So 9 from 10 patients will have IMG immunoglobulin to uveitis. So when there is non-characteristical clinical picture, it is not necessary to send them make tests for torch analysis. All these manifestation has very usual and widespread clinical signs. These are marks of immune suppression. These are patients with HIV. When a patient has HIV, it is not necessary to make this list of analysis. Another one interesting analysis: practically all patients with uveitis come to us with remo samples when C-reactive protein can be increased when a person had increased weight or he is smoking. If we're talking about the C-reactive, it is informative for rheumatologists to assess the activity of inflammation. Rheuma factor is very interesting analysis. It is positive when a person has arthritis or Shanghai syndrome, and in most cases it is practically non-widespread. Then streptococcus infection, another one interesting test. And generally, if we are talking about types of uveitis, 2/3 of them are anterior uveitis, but all over the world, from 85 to 19% of uveitis are autoimmune uveitis. HLA, it is the most widespread reason for uveitis development, and it's a seronegative arthropathy group. Why they are called seronegative? Because they are seronegative as to this remo factor. If we prescribe remo samples to these patients and results are negative, it's a normal situation because LHB27 will be positive. And then on our alive examples patients, I want to tell you this confusement of analysis. This is a patient with a HLB associated uveitis, but she has had uveitis for 20 years, and we revealed HLBA only 5 years ago. Right eye is blind, and left eye is with a bad vision. She gets corticosteroids, she is stable, but unfortunately we lost time. It was necessary to prescribe necessary tests in a timely manner. Another example, we had a patient. So she had a treatment for 2 months in her residential hospital. She was with a positive test on HLA B27. Was it necessary? No, it was necessary because she had only herpes-associated anterior uveitis, and this test was non-informative. And in other similar example, HLA-positive patient, she has got treatment for 1 or 2 weeks. It was considered to be autoimmune uveitis, but we can see the same clinical picture. What about analysis and their necessity? Of course, we can't exclude that after some recurrences of this case, it can be LB27 associated uveitis, so we should pay attention to this. Another one example, a patient, left eye anterior and middle uveitis, several months of treatment at the place of residence, but there were two pink foci on her right eye. And these are no signs of posterior uveitis. And except for HLA-B27 positive, she had some systematic complaints. But her situation and her description was that she had complaints on eyes after gynecological surgery. And we had the same two patients, and they were operated by the same medical brigades. They have the same symptoms. You can see here choroiditis with blast and with infiltration into retina. We think that it is associated with anesthesia. So here HLA positive is not connected to the uveitis etiology. Another one interesting example, when in general all analysis results are negative. What should we do to provide treatment to this patient? We had a patient with chloritis 1 year ago. Unfortunately, we didn't have a photo made 1 year ago, but it's his result several months ago. During the first episodes, all his test results were negative. CT, palm CT was within normal range. It was considered to be autoimmune, and treatment was corticosteroid eye drops. He connected all the recurrences with his teeth diseases or ear and throat organs diseases. We prescribed him corticosteroids in drops as previously, and during the month his condition has worsened, and the Flickton nodule was formed. We repeated tests one more time. Quantiferon test was also a negative, so we had signs of TB associated uveitis, but we saw a very positive dynamic of after the usage of isoniazidis. And now his etiology is proven, and he has proper treatment. Another one example of uveitis and spiritis, adult women with a 5-year-old uveitis with the complications and performed surgery on cataract. This eye has better visual acuity. As you can see, 3 years ago, she was revealed positive blood, but rheumatologists ignored these results. But half a year ago, they made her immunoglobulin, and it was one vague indication, but it is not CNP++, but it is very vague site, and it was ignored, and she got wrong treatment on berylliosis. She was referred to us. She had uveitis, scleritis, necrotic scleritis, centromere antibodies were positive, and CNP also positive. Rheumatologists can't prove these diagnoses, and we have 2 points: polyangiomyelitis or sclerotopia. Also, very interesting example when a test is not corresponded and connected to the clinical picture. She referred to us with anterior uveitis and scleritis. All the tests were negative. We suspected vaginal grammatolosis, but ANC was negative. But still we had a consultation due to this disease. In a year there was a positive dynamics, and there was no threat of perforation. Answer analysis began to be positive on protein kinase, which is character for Wegener. And also she had inflammation foci in palms. Then he disappeared, he didn't visit us, and she didn't get systemic therapy. It's scleronecrosis. Of course, she's blind on this year, and she had necrotic impairment of lungs and other organs, and we didn't see her. I didn't tell you in details, but I want to highlight about the number of tests that shouldn't be prescribed. When we have chorioretinitis, it can be both toxo or TB. There are no options. Look how many tests there were performed. Even HLB27, which didn't provoke posterior uveitis, and he got wrong treatment before us. He was prescribed corticosteroids, and from one small TB focal, we got grammatolosis. Thank you very much for your attention. Thank you for very interesting report. And now I will give the floor to Victoria.
Відділу запальних захворювань.
To Kolesnichenko Victoria Alexandrovna to speak about the shadow theater in uveitis. Greetings, dear colleagues. To finalize our section, a small report, more of a philosophical nature, but I hope it will be useful. The name is really poetic, but what is there behind the name? When we speak about medicine and ophthalmology in particular, we understand that it is not always that we see clinically what we see with our own eyes means that we see indeed what we suspect. And none of the narrow specializations can have so many extraordinary cases, as in ophthalmology with our uveitis. The slide shows three different photos, all of which look like uveitis, but in fact none of them is. The first photo shows a lymphoma, the second hypopyon, and destruction of the vitreous body. It is not always, we don't always figure out what we actually see. Masking syndrome, for example, or masquerade syndrome, which the term of which is often found in Western literature. So this is a kind of challenge which we have to take, and we have to answer certain questions like what do we see in front of us. And this slide shows three more pictures with some problems with vitreous body, something light, something white, dark. The first photo shows destruction of vitreous body. The second is destruction due to tuberculosis, and the third shows asteroid hyalosis associated with cholesterol. All three cases have absolutely different tactics of treatment. The first is more of rheumatologist's work, the second is an infectious disease, and the third one is within the competence of retrovitreal surgeons whose job it is to do the surgery and treat such patient in this way. The mistakes begin directly with diagnostics. The picture of uveitis is difficult and multifacial. One shouldn't fit some other diagnosis into the criteria and symptoms of uveitis. If some of the symptoms or some point in the anamnesis does not fit into the picture which you suspect, you should continue looking for explanations. You should continue, even if we don't, even if we are not able to reach consensus. But anyway, what has to be excluded first. Only afterwards you can establish the correct diagnosis, keeping calm. This slide shows several cases which we face pretty often. We see anterior uveitis, which was treated with topical corticosteroids, and 3 months after, granulose precipitates were formed, and other similar examples. What helps us to resolve such shadow issues? This is multidisciplinary approach. We are really happy that during all the years of work in our department, we have so many colleagues who we trust and who help us. So if one has doubts about some uveitis, one doesn't have to be afraid to let a patient go and refer to a systemic specialist like rheumatologist. We shouldn't be scared to lose a patient, but we should explain such patient that his or her pathology requires advice of several specialists, which is not bad. It's great to keep in touch with colleagues of other specialties and to achieve nice results for the patient. Where else do we face the shadows in diagnostics of uveitis? What Alexandra Eduardovna has explained to us in detail, this is the two-sidedness, 2 points of view, two different and controversial methods. One is over-treatment and the other is under-treatment. Exceeding amount of tests done and very few tests which are not enough for diagnostics. But what should we start with? We should start with common blood tests. We should start with rumor tests. We should try to find that particular test which will help you to establish final diagnosis. You should first of all understand what to start with. What concerns treatment, there are also cases, there have been cases in our practice when we saw patients who had long-term treatments at their residence place or in other countries, patients with idiopathic uveitis, for example, without exclusion of other pathologies which could have caused particularly that condition, but they obtained glucocorticosteroid therapy, for example, or different other long-term therapies. Such patients usually arrive to us with side effects, with consequences, and treatment of such patients is always a hard choice because we are really thorough, really careful in diagnosing and in choosing the correct treatment, looking at the response of these patients to the treatment they have already undergone and the treatment that we are prescribing. We would like to see positive dynamics, of course, but it's not always possible. In cases when etiology is known, etiology of the uveitis is unknown, then there is not too much time for us to doubt and to consider, and we should probably take this patient into inpatient treatment mode. And I remind you that Philatov's Institute and the Department of Inflammatory Diseases of the Eye is always ready to help, is always ready to accept patients. So if you start treatment and you are not always sure that you can finish it and bring it to the successful outcome, I mean, you can count on us, or you can count on our inpatient department. Speaking about shadows, here is a clinical case from our institute. The first slide shows the fundus with the following situation. The patient noticed decrease of quality of vision, whereas his visual acuity was 100%. So he referred to ophthalmologist and he was thorough in explaining his complaints. He noticed that the colors became less bright, but the visual acuity still was 100%. The fundus looks nice, not bad, but the patient was offered long-term eye drops with vitamins. to facilitate the condition. Unfortunately, this patient, a military man, he didn't have opportunity to refer to us, and his quality of vision kept on worsening, especially in darker period, but his visual acuity remained 100%, so he could not prove to the doctors that something was wrong with his vision until he arrived to us. And the first two tests, fluorescent angiography and OCT, showed us total lesion of the blood vessels of the eye. So this is chorioretinitis, and you see that looking at the fundus, one cannot even suspect that the problem is so massive. All these photos, by the way, the fundus, OCT, and angiography were done on one day. So from the first look, something might seem easier, simpler than it actually is. So keep that in mind, please. Thank you very much for your attention. We are looking forward to inter-regional conferences and to further cooperation. Thank you very much. We are finishing our section. We have started it